Okay, wait a minute. Okay. All right. So we have a half an hour to go through one whole chapter, and that you said you didn't really understand. So this is what I need to ask. I've gotten feedback from some of you who have said you want me to really, like it when I explain these slides, but if I explain them to the point that I did chapter 2, we're not going to get through, all of them and let you do your quizzes and all that stuff as well. So, am I going too slow? Am I explaining too much? Or do you like it this way?
It doesn't really matter to me anyways.
Okay.
Yeah, whatever works for you.
Okay, well, I can go faster. I just am trying to do this for you guys on this, so it doesn't matter. But what I will do is I'm going to record this and this chapter, and I'll keep going. So at 11:30, if any of you want to go, you can. And if you want to stay on for this, then I will continue. Okay.
Okay, sounds good.
All right. So here is, now we're going to talk about the vasoconstrictors. Can you see the screen?
Yes.
Okay.
Yeah.
Okay, so in this chapter, the very first sentence in your textbook says all clinically effective injectable local anesthetics that we use today are vasodilators. So this is what I want you to get. My first sentence says most local anesthetics are vasodilators. And the reason is because of cocaine being, since it first is a vasodilator, you can say that all of them are vasodilators. It's just that you're going to get questions that will say, what is the most powerful vasoconstrictor, which is cocaine, and that's because, like I said a couple times before, cocaine it first vasodilates, and just for a really short amount of time, and then it super constricts. So it depends on how your question is asked. If you have words, as how you're going to answer that. Okay. So the degree of vasodilation varies. Procaine is the most potent, powerful vasodilator, and prilocaine and mepivacaine are the least potent vasodilatory properties. So that's why I was saying before that some dilate the blood vessel more than others, and so it as much cannot lidocaine, because they don't make lidocaine plain anymore because it was never used. So your only option is, if you use 2% lidocaine, is to have it with epinephrine. So you get a patient that cannot have epinephrine, then you would choose mepivacaine plain, because it does not have, and we do mepivacaine and prilocaine because they don't dilate the blood vessels as much as the other ones. So that would be the next best thing to use. And we don't use prilocaine a lot because of the problems with orthotoluidine and breaking down on the breakdown of that, and possibly hemoglobinemia. Okay, so that leaves mepivacaine. For us. There may be some practices out there, some specialty practices that like the other properties of prilocaine, but most general practitioners will probably not use prilocaine even for you to choose. So the degree of how much it's going to dilate depends on what anesthetic you're using, and the injection site. Does it have tons and tons of blood vessels or just some blood vessels, and the individual's response to that, which can make a difference. Dilation of the blood vessels cause an increase in blood flow to the site of injection. Perfusion is blood flow. And so the more dilated it is, it's going to carry some of the anesthetic away. So going to have a lot more blood flow to your site. So an increased rate of anesthetic absorption into the bloodstream, increasing toxicity. It causes a decrease in the duration, how long the anesthetic is going to last. Increased bleeding in the area due to more blood flow, and higher blood plasma levels, just like we've said in the chapter before. Okay, these disadvantages can be overcome by using.
We had a conversation a while back about children. How much do you need? What is this? A plan? Look at this right now.
Your mic's on.
You obviously not saying that. Move. Let's go.
Okay. All of that stuff that we just talked about on the previous slide can be overcome if you use a vasoconstrictor and you add that. So vasoconstrictors, you may also, is interchangeable with the word vasopressor. They may say a vasopressor will be added. They mean a vasoconstrictor. And you can remember that because, of course, vaso at the beginning of the word means blood vessel, and pressor. If you press on a blood vessel and press it down really, really hard, you're constricting it. So remember that pressors are constrictors. It's helpful in dentistry where long duration and more profound anesthesia are required. So they're going to lengthen the time. It's like lidocaine plain. When they had that, only gave pulpal anesthesia for like 5 to 10 minutes. And what can you SRP in 5 to 10 minutes? You'd have to be giving, 6 injections or 5 more injections for the hour, just to have them numb for the hour. So if we add a vasoconstrictor with it, it automatically increases the length of time of the numbing to 60 minutes. Okay, so, and it's more profound anesthesia, which means they're going to feel it deeper. They won't come out of it and say, I kind of feel numb, but I kind of don't. They're going to feel numb. So vasoconstrictors are drugs that constrict blood vessels, and so thereby they control tissue perfusion, which just means controls tissue bleeding. It's going to constrict those blood vessels and not allow a lot of blood to come into your area. So they're added to local anesthetics to oppose the natural vasodilatory action of the local anesthetics. So they're used with injected local anesthetics and are chemically identical or similar to our own nervous system mediators. So our sympathetic nervous system mediators in our body are epinephrine and norepinephrine. So the hormones that we make in our body are like epinephrine, norepinephrine, dopamine. Now, this doesn't have a lot of effect on dopamine, but it is very similar to the one ourselves, just naturally in our body. So that's why they work so well. We don't use norepinephrine, however, for other reasons that we'll learn later, but epinephrine is the one that we will choose, most likely. The only two vasoconstrictors that are routinely found in dental local anesthetics in all of North America are epinephrine and levonorepinephrine. So can be put with many different anesthetics. You'll see prilocaine with epinephrine. You'll see bupivacaine with epinephrine. You'll see lidocaine with epinephrine. The only one that you're going to see with levonorepinephrine is 2% bupivacaine. So when we use bupivacaine vasoconstrictor, we're using 3% bupivacaine plain. But when they put a vasoconstrictor with it, they lower the first amount to 2% instead of 3%, and they added levonorepinephrine in order to make it as powerful as your lidocaine with epi 1 in 50,000 or 1 in 100,000. They have to increase the vasoconstrictor strength to 20,000 to make it like it with levonorepinephrine. Okay, so vasoconstrictor actions so resemble our own response of our adrenergic nerves to any kind of stimulation that they're classified as sympathomimetic or adrenergic drugs. So when you see mimetic at the end of that word, it means it mimics our sympathetic nervous system. Okay, so vasoconstrictors are classified as mimicking our sympathetic nervous mediators, epinephrine and norepinephrine. But they have another name that they use interchangeably with this, and it's also called an adrenergic drug. So catecholamines, we have hydroxyl and an amine group. So that's OH and NH2. So I never have seen yet a lot of questions about that. OH and NH2, that's talking about the chemical structure with the geometric figures, and you put NH and OH by some of them. But the important thing to know about this is that the catecholamines and the sympathomimetic, epinephrine are sympathetic fight or flight hormones. And the sympathetic fight or flight hormones are released by our adrenal glands in response to any kind of stress. So the naturally occurring catecholamines sympathetic nervous system are epinephrine and norepinephrine. Both are stress hormones and neurotransmitters. They transmit for nerve transmitters. Dopamine is the third one. It's a neurotransmitter. It was a precursor to epi and norepinephrine. It should feel good and focus. But the naturally occurring catecholamines does not include dopamine. That we're concerned with here does not include dopamine. It's just going to be your questions on tests and review books are going to be talking about epinephrine and norepinephrine. So these sympathomimetic drugs, because they mimic our own epinephrine and norepinephrine, they are direct acting on adrenergic receptors, alpha and beta. So you need to know that you remember that they are Greek words, alpha and beta, and all of the local anesthetics have a direct effect on our alpha and beta, and you'll see why in a minute. So epinephrine, norepinephrine, and levonorepinephrine all activate those adrenergic receptors, alpha and beta. So all those receptors are found in most body tissues in our whole body, and they're divided into two types of adrenergic or sympathomimetic receptors. The alpha and beta part. Alpha, the main function of the alpha, if the local anesthetic affects the alpha part, it's going to excite, which means constrict or stimulate, constrict, and inhibit, which means dilate. And they have both actions, but on alpha, the main one that it does the most is constrict blood vessels on the heart. And this is of epinephrine, norepinephrine, levo. And then it also, that local anesthetic affects beta receptors, and that inhibits and excites too, but it mainly inhibits or dilates. That's the main action. So it dilates the blood vessels and the lungs and heart stimulation. So epinephrine, once again, acts directly on both alpha and beta. Epinephrine activates the alpha receptors, which is vasoconstriction, and epinephrine activates the beta, which is mostly vasodilation. So you'll have people who you'll give an injection to that may have what they call an epi reaction, epinephrine reaction. Their heart starts beating faster, they could start sweating and feeling like there's a pounding in the chest. That's the epi, which has a direct effect on the central nervous stimulation, and that's called an epi reaction. They may just, if you put them down and have them breathe deeply and whatever, they can come right out of that. Or they may just keep going into it enough that they affect. And usually you'll hear a doctor or a hygienist say, oh, they're having an epi reaction. So your alpha and beta are both broken down in two ways. You have an alpha 1 and an alpha 2. So alpha mainly vasoconstricts, smooth muscle in the blood vessel. Alpha 1 receptors are constriction, they're excitatory constriction on the heart. And alpha 2 receptors, which is your lesser occurrence on these, are some of them will dilate. Most of them are going to constrict, majority. The beta actions have a beta 1 and beta 2. And these are mostly what we're concerned with, is the beta reaction. Out of alpha and beta receptors, beta dominate. Okay, so it's going to have an effect on the beta more than the alpha. The beta 1 is heart muscle constriction, just like alpha 1. And beta 2 is relaxation or inhibition, just like alpha 2. It's going to vasodilate and bronchodilation of the lungs and dilation of the coronary arteries. Remember the coronary arteries in medical emergencies, those were you had a picture of the heart, and then it had a picture of all these tiny little blood vessels that are surrounding the outside of the heart, where embolisms and clots can form. Well, those are the coronary arteries. And what epinephrine does is it will dilate those coronary arteries, and it dilates the lungs. It relaxes all the smooth muscles so they can dilate, which is why they give people an EpiPen. Okay, so when you're having an anaphylactic reaction to something else, an allergy or allergen or whatever, and your throat is closing shut and you feel like you can't breathe, and they give you an EpiPen, it has both alpha and beta, but the beta actions are going to predominate, and it's going to constrict the muscle of the heart a little bit, and then it's going to dilate your lungs and your coronary arteries, which allows you to breathe. So the way that we always remembered this is we had this back in my day. You have one heart and two lungs. We actually have three lobes, but we're going to say two lungs. Beta 1 receptors primarily on the heart. So beta 1 goes with the heart, of which you have one. Beta 2 receptors are primarily on the lungs, and you have two. So you can remember that beta 1, we have one heart, that has to go with the heart. Beta 2, we have two lungs, it has to go with primarily on the lungs. And I think that's the way we remembered it for our boards.
So I'm confused though, because I thought epi was added into the anesthetic to help constrict the blood vessels, since the anesthetic itself is a vasodilator.
It is, you're correct. But when it has, it can have these types of effects on the heart and the lungs, like if you're given more than two cartridges. And given more than two cartridges is not bad at all on someone unless they have an issue, systemically. So even on a healthy person, when they're given an anesthetic, with epi, the epi is going to work on have a direct effect on alpha and beta predominating. So it's mostly the beta. It's going to cause you to be able to breathe a little bit better and dilate relax and dilate the coronary arteries. So it's a help. So you'll have people who will come in with a med history and they'll say, I'm on a beta blocker. So they're taking a medicine that's blocking this beta action. So let's say that they have a constant rapid heartbeat. Or no, they don't have, let's say that they have trouble breathing a lot. They would be given a drug with a beta in it to help, or epinephrine in it to help dilate that. And the opposite is also true. Some people need their lungs and blood vessels to be a little more constricted. And so they would be given a beta blocker to block this beta action of heart constriction, heart muscle constriction, and then dilation in the lungs and the coronary arteries.
So I have a question.
Okay.
So for a beta blocker medication, you would give them an epi-filled drug to help cancel that out?
No, you wouldn't want to give them very much epi if they're taking something, a medication to block the beta action. So we would not go ahead and give them something that's going to give them beta action because they're trying to block it.
No, I'm saying the medication they were on would have epi in it.
I don't know I don't know. It's usually in a pill form.
Okay.
So it may be something else other than, I never really know that it has epi.
Okay.
So vasoconstrictor drugs, the benefits versus the risks. Endogenous release of epinephrine. Okay, so endogenous release of epinephrine in a person's body is when we give them an anesthetic from the outside. They're not making it in their body. we're giving it to them from the outside in, and we're giving them dose of epinephrine. Okay, so we have to do the benefits and risks of giving them a release of epinephrine and the release of epinephrine from what they're already experiencing in their own body. So if you get someone that has anxious and white knuckling the chair arm because they are so nervous to be at a dental and they've never had an injection, or maybe have, and they hate them, and they're just making themselves just almost hyperventilate. They're releasing so much epinephrine in their body already, because all of that anxiousness is releasing the epinephrine is another word for adrenaline. Same thing. So their adrenaline is flowing already to the max, and then we're going to give them some more. Okay, their heartbeat is already going, and they're super unhappy, and they are just a mess. And then we're going to give them a local anesthetic with more epinephrine. So we have to be aware. That's another reason that they're ASA2 patients, health-wise, because it just gives us a little like, why are they ASA2? And then you look at that and go, oh, because they're probably going to be releasing a lot of epi. So it may be that you could use mepivacaine without the epi in it, mepivacaine plain. Or it may be that they really have to have lidocaine because of its, mepivacaine doesn't last as long. It's not numb as long. Lidocaine will be numb longer, so maybe they need that epinephrine in there, but we just give a cardiac dose to that person. Okay, so in the case of stress, the patient's blood level of epinephrine is already higher than normal, and then we add a local anesthetic with epi, making the blood level even higher. However, at a 1 in 100,000 epi amount, the blood pressure and heart rate are minimally affected. So that's why we'll say give them, maybe we'll do a cardiac dose for that day. They can come back the very next day and have another one, but not at the same time. So vasoconstrictor drugs, benefits versus risks. The elevation of epinephrine blood levels in a dose is dependent and persists from several minutes to a half an hour. So we don't leave the patient alone after giving a local anesthetic. And this is what I meant when it comes to epi. They can have an epi reaction for maybe up to a half an hour. So I just don't leave them alone. New evidence supports that epinephrine levels are equal to moderate to heavy exercise after an oral injection. Most people, it doesn't affect anything at all. Don't think you're going to be having this all the time. But it is possible. Those who should not receive an anesthetic with a vasoconstrictor include patients with a recent myocardial infarction, so a recent heart attack, coronary bypass surgery, or a stroke within the past 6 months. They should not be receiving, and usually they won't even have dental care during that time. But if they do come, if they've had it, now if they had it 7 months ago, you can go ahead and give it to them, probably in a cardiac dose. Patients with uncontrolled high blood pressure, chest pain, angina, arrhythmias, where your heart is kind of shaky, diabetes, and hyperthyroidism. But the hyperthyroidism, this is all controlled. If they have controlled hyperthyroidism, you can give them an injection, a drug with epi. But how you'll know the difference if it's uncontrolled hyperthyroidism is if their eyes, if they're showing clinical signs that you can see, like their eyes are bugged out and they have big goiters, on their neck, and that kind of thing. When you back in medical emergencies, when we saw the difference between hypothyroid or a myxedema coma and a thyroid storm, when they really were full blown. If they have that, it's uncontrolled. If they don't have that, it's usually controlled. So only if they have uncontrolled blood pressure and the rest of that. But they can possibly have a cardiac dose. Depends on if a doctor has sent them to us that they need this before another operation or not. Depends on how serious it is. Now, all of these we're going to go over. You're not going to do any of this until we do our calculations. So just forget that. So available in the United States today is 2% lidocaine with epi 1 in 50,000 or 2% lidocaine with epi 1 in 100,000. That's what's available. They don't have anything else. So here we go with epinephrine. Epinephrine is also adrenaline, and you can see in the concentrations it comes 1 in 50,000 or 1 in 100,000, and now it even comes in 1 in 200,000. So that's different levels of epinephrine, which means that the only difference is that they would have, with the 1 in 200,000, they'd have less amount of epi running around their system. It'd be really diluted, and there wouldn't be as much control of bleeding. So levonorepinephrine, another name for that, if you ever see neocobephrine, and they only have one concentration ratio, and that's 1 in 20,000 with 2% mepivacaine only. It doesn't go with any other one. And 2% mepivacaine, they don't have a 2% mepivacaine plain. It's only 3% mepivacaine plain. The only times you'll see 2% is when it's combined with this vasoconstrictor levonorepinephrine. And they have that for people who cannot have, in emergency situations, for people who cannot have epinephrine at all. So epinephrine, adrenaline, the most useful and best example of a drug mimicking the activities of our sympathetic system is epinephrine. It's just almost exactly like it, the man-made stuff. That's why it works so well. Actions of other drugs are compared to epinephrine, just like they compare all the local anesthetics to lidocaine. When it comes to epinephrine, they compare anything to epinephrine. That's why on levonorepinephrine, they had to make it so strong, 1 in 20,000, in order to make it hopefully as good as epinephrine. So epinephrine in itself is an acid salt. And an acid, it's highly soluble in water, and it's an acid base. You're going to find, and that I would just memorize. Don't try to go in. It's such a big explanation that you don't need to cloud your brain. The only thing that I see in about this is that some of the one question that they had in a review book was epinephrine is a base, like true or false, and it can be an acid base. You can have an acid salt be a base. So I don't have any of that, but epinephrine is an acid salt. Slightly acidic solutions are stable relatively and protected from air. So the way that they do that is by putting a antioxidant with it, which in this case, in all of epinephrines, they put sodium bisulfite. You may see it as sodium sulfite. So sodium bisulfite or sodium sulfite is added to epi, and it's added to delay the deterioration of it. Epi breaks down easy in air. And so they add this to it to give it a longer shelf life and keep it. A local solution without a vasoconstrictor will last 36 months. And if you put a vasoconstrictor with it, it lasts 18 months. So already the vasoconstrictor lessens the amount of time, but at least we can get it to 18 months. Epinephrine actions on specific systems. Epinephrine acts directly, like we said, on both beta receptors. The beta effects predominate, which means vasodilation of the coronary arteries and dilation of the lungs. On the heart, both of the alpha and beta 1 and 2 have effects on the heart. They stimulate the beta receptors, increase heart rate and cardiac output. Also the beta 2. Mainly what you have to know about this is that they will stimulate the heart rate and dilate the blood vessels and the lungs and the coronary arteries, we've already said. So how does it affect epinephrine affect blood pressure? In really small doses, epinephrine can increase your systolic pressure just a little and decrease the diastolic. But in high doses of epinephrine, it may just increase the diastolic pressure, what your blood pressure is at rest. So the cardiovascular system, how does epinephrine affect that? It's mostly the beta 1 effects on your cardiovascular. I don't have any really questions about that, except that on the cardiovascular system, epinephrine, there's an overall decrease in cardiac efficiency. It doesn't mean it's horribly bad. It just is not, it's going to increase the output and heart rate. And the contraction with 1 or 2 cartridges. And so your heart just isn't working like it normally should, but it's not horribly bad. It doesn't have as much cardio efficiency because it has an effect on it. That's all it means. Metabolic, how does epinephrine affect that? Epinephrine can inhibit insulin secretion in the diabetic. Now, I don't really notice anything unless a person is an uncontrolled diabetic. Would I even worry about this? We give epinephrine to diabetic patients all the time with nothing, no reaction. Epinephrine actions on specific systems and tissues. On the respiratory system. On the respiratory system, it's the beta 2 effects that are mostly dominant. Because remember, it's a bronchial dilator like your EpiPen. And it's going to dilate the lungs and dilate the coronary arteries of the heart. So treatment, they give it for treatment of acute asthmatic attacks and anaphylactic reactions on the central nervous system. A normal dose does not stimulate the central nervous system at all. It's only when there's an overdose that you're going to have anxiety, nausea, restlessness, weakness, tremor, headache, hyperventilation. And on some of these, overdose means that you give more than 11 cartridges. Are you ever going to give somebody 11 cartridges in SRP? No. So don't really have to worry about that. Yeah.
When you say normal dose, do you mean a cardiac dose or just normal for like the situation you're doing?
Mostly a cardiac dose.
Okay. So normal dose in this situation would be just 2.
Most of the time you give, like in one setting, if you're going to do the upper right and the lower right, depending, and they're caked with calculus and they have super deep pockets, there's a way to work it out on the maxillary where you can give X amount to the maxillary and just use a stronger anesthetic like 4% Septocaine or Articaine. and it has 1 in 100,000 epi, and it's so strong and it's really deep, profound anesthesia. It's good. You can give that, you can give a smaller amount of that to each injection. So it makes it last longer and you can work it out. You just never give a 4% to an IA, and we'll explain that later, but a 4% any anesthetic. But we'll get into that later.
Okay, thank you.
Hemostasis. Hemostasis means bleeding control. So they like epinephrine for its hemostasis effect. In high doses, it's going to stimulate the alpha receptors, which results in the alpha in basically vasoconstriction. That's when we like to use it. So the maximum dose of epinephrine, 1 cartridge equals 1.8 milliliters. So all the math I'm going to go into and we're going to do all of the calculations at once because I think it's going to make more sense to you. So what you need to know, I'll just memorize, and this you just got to memorize. One or both of these questions was on my boards, and at least one, if not both of those questions, will be on your boards. It's that important. So healthy patient can only have 0.2 milligrams of epinephrine. A medically compromised patient can have, the highest max dose they can have is 0.04. So 0.04 of a milligram or 0.2 of a milligram for a healthy patient. And so I will go into what the whys and wherefores at a later point, but you're not going to want to start doing math. I'll tell you right now, when you have these questions, it's better off just to keep saying it over and over and over to yourself and writing it down and over until you just friggin' know it. I'm just saying. So all of the above calculations are for an epi 1 in 100,000 dosage. So we're always going to use the lowest possible dose. We're going to properly aspirate. We're going to inject slowly and use a proper technique, and you'll be fine. Hemostasis is decreasing the bleeding at the site of injection. So a 1 in 50,000 epi is more effective than a 1 in 100,000. That's why the 1 in 50,000 is used for surgery. So a 1 in 200,000 is sufficient enough for SRP as well. So you can, even though we're going to do SRP, they have found out that just because we dilute the epi a little bit in a 1 in 100,000, it's okay. It's effective enough for bleeding control and constrictor control for our SOPs. We don't need to do the 1 in 50 and give them a stronger amount. So 1 in 100,000 for patients who are sensitive to catecholamines. Now let's talk about levonorepinephrine, or it's also called neocorbephrine. Not going to talk a lot about the ones that aren't good and we don't use, and when we get a little further along, but levonorepinephrine is also a man-made vasoconstrictor. It's only 1/6 as potent as epinephrine, even though they try to make it higher. So it was manufactured in higher concentrations to up the potency. It's only available with 2% mepivacaine and a 1 in 20,000 milligram to milliliter to achieve the same effects as the epi 1 in 100,000. It does contain sodium bisulfite. So the preservative, just like epinephrine, it has to have a preservative in it for shelf life since it's a vasoconstrictor. It provides significantly less bleeding control than epi though. But it can be used in dentistry as an alternative to epi if epi for some reason can't be used.
Did you say that for shelf life it has to have a preservative in it?
Yes.
Why is that?
And
So
because it's not stable in air. Levonorepinephrine, all vasoconstrictors break down more than local anesthetics, and the vasoconstrictor to keep, like heat can destroy the effects. If you kept in your office, if you kept your local anesthetic boxes or blisters or whatever, in like by a window with the sun heat and everything, that can destroy the effects of the epi as well, or levonorepinephrine. But they just have to have a preservative with it, and it's always sodium bisulfite, or you may see it as sodium sulfite. It's the same thing.
Okay, thank you.
Let's talk about norepinephrine, but not a lot. I never knew it by the word, don't even know how to pronounce levonorepinephrine or whatever, and never see that. But norepinephrine, they may have questions on only based on the fact that they don't recommend it. It's not recommended for use in dentistry and not sold even in the whole United States. It's so bad. And the authors of most of the books feel like it should be eliminated altogether and shouldn't even be around. The side effects of using norepinephrine are 9 times more potent than epinephrine. So the pain control, however, is only 1/4 of epinephrine that epinephrine has. So it's like it can cause death of the tissue, which is necrosis, with excessive use. So that's why it's not even sold. They have it in some European countries, and I'm not sure what they use it for, but we don't use it here. This is what it can cause. Norepinephrine overdose response is soft tissue. That's on the palate. And they gave an injection and it just killed the tissue. So naturally, all you need to know about norepinephrine is that it can cause tissue death and is not as strong pain-wise as epinephrine. And it's not sold in the United States. We don't use it. Now we're going to talk about phenylephrine, which is another for neosynephrine. And we all know that name in grocery stores for nose sprays are neosynephrine nose sprays. You will recognize that. They used to use this. It's no longer used in dentistry. Tachyphylaxis was noted that they used it a little bit and then it didn't work anymore. It is still in use today in nose sprays and other things, but we don't use it in dentistry. That's about all you need to know about that. Felipressin is not available in the United States, and I'm not even going to go through it and bog your mind up with it. I never see anything about it except they may have felipressin and phenylephrine or the word neosynephrine in a matching question to where it'll say what is available in the United States or what is not available in the United States, and it would be only in that vein. Let's talk about bleeding control, hemostasis. Concentrated epinephrine is 1 in 50,000. That amount ratio provides the greatest hemostasis, and it's used for surgery. But like I said before, and it's a test question, studies do show effective bleeding control by using just 1 in 100,000 epi for our SRP procedures. Patients have reported that there is no difference in pain control between 1 in 50 and 1 in 100,000 dilution. So we would, if there's no difference in pain control, we'd rather use the 1 in 100,000 because it's less concentrated. Why put more epi, even if they're not really affected by epinephrine? Why put more in their system than they need? We're always looking to use the least amount. Epinephrine is rapidly inactivated in the bloodstream. So diluted epinephrine, 1 in 200,000, is safer for cardiovascular compromised patients. It's inactivated quickly in the bloodstream, and it's a really diluted amount of epinephrine, so we would probably use that within a cardiac dose. So how do we select a vasoconstrictor? Well, number one, in the United States, there's only 2. So that makes a pretty easy selection. And the factors that you need to consider are the length of your procedure. If you want something, how are you going to decide whether you need an anesthetic that's plain, like 3% bupivacaine versus 2% lidocaine with a vasoconstrictor? You're going to say, what I'm going to do is only going to take 10 minutes or 20 minutes. Well, then use bupivacaine. Okay, because it only lasts that long. Why give him something that's going to deaden for an hour if you don't need bleeding control or anything else? So you might use that. But if you need anything more, like we do on SRP, then you need to use a vasoconstrictor. Or you need them to have a profound, deep anesthesia. You're going to go deep in their pockets. Then you need to use a vasoconstrictor. So need for bleeding control during and after the procedures, you would select a vaso. Need for post-op pain control, and the medical status of the patient, depending on what issues that they have. The addition of any vasoactive drug to a local anesthetic prolongs the duration and depth of pulpal and soft tissue anesthesia and most anesthetics. Example, 2% lidocaine HCl, which means plain, a salt, provides pulpal and hard tissue for approximately 5 to 10 minutes. If you add epinephrine, it increases it 6 times fold. So all epinephrine usually will increase whatever duration is to 60 minutes immediately. And usually plain does not last that long. Bupivacaine's the longest, and it's anywhere from 20 to 40 minutes numbing max. So the addition of a vasoconstrictor to prilocaine, though, does not significantly increase that duration on prilocaine for some reason. Typical patient is only scheduled for an hour appointment in your private practice, and your duration of treatment is really only about 47, 48, maybe 50 minutes. Then you have to stop and have your doctor come in, and he or she will do their exam. So it works fine. If we have something that will last at least 60 minutes, it's great. That's about the time that we need. Now, over in the clinic, we need it to last a little longer. You may be given some more. So the durations of pulpal anesthesia between an infiltration and a nerve block are different. An infiltration is an injection that is going to get just one and maybe half of another tooth. We just want to get that one tooth. And a nerve block is going to get several teeth, 2 to 3 teeth. A nerve block is going to be further away from the tooth. You're going to go further into the tissue to get to a nerve that will anesthetize like 3 teeth at a time. An infiltration is right at the apex of the root of that tooth usually. So obviously the duration of a nerve block is longer. You'll get longer amount of time when you do a nerve block than if you do an infiltration on one tooth. So requirements for bleeding control. Epi prevents or minimizes blood loss during surgical procedures. But this is the thing. You need to know this exactly the way it is. But I got to tell you the truth in this. Not that this is lying, but it's only really going to control bleeding for surgery if you put the injection right into the wound. That's what they do in the doctors. Hospitals. They put the injection right into the wound. We don't do that. So don't be surprised if you use epi if you're still going to get some bleeding in the clinic. Don't think you did something wrong. We don't want to go into a site of inflammation because it's going to carry our anesthetic away, which we'll get into. Epinephrine possesses both alpha and beta reactions or actions. Epi produces a rebound vasodilatory effect as the tissue level of epi declines. So what that means is that you have, just like we studied in medical emergencies, do you guys remember about the rebound vasodilatory after you pull a tooth? So what this is the epi starts to wear off faster than anything, the anesthetic. So let's say that you have a tooth extracted, and then at 3 o'clock in the afternoon, and then you go home, and the clot is forming and all of that, and about 6 hours later your tooth starts to bleed again. Okay, or 3 hours later. And you're like, gosh, what did I do? It's starting to bleed. It's because the epi is a constrictor. And so if the epi in that anesthetic, the anesthetic may still be numbing it, but the epi in it is wearing off. So as it wears off, the dilatory action, vasodilation of your anesthetic is still there. So the blood vessels are going to start to dilate, and you may experience some more bleeding hours later. And they call that rebound vasodilatory effect as the epi starts to go away or decline.
I have a quick question.
Sure.
Okay.
Okay.
Would you select a anesthetic that has epi in it if you have a heavy smoker as your patient?
Oh, good question. Yes, I probably would, because in weighing the risks and the benefits, I would want the benefit of it, the duration and the strength of the anesthesia, more than worrying about the constriction of the blood. I don't hear much about that, so I don't think that's probably much of an issue. I've never really read anything about don't give them epi. But what you wouldn't want to do if you use something, let's say they were at our clinic and you needed to work for at least 2 hours on them, and you gave them mepivacaine plain, which doesn't have any epi in it, it means, depending on how they are, every 20 to 40 minutes, you're going to have to restick them. You know what I'm saying? So if you use epinephrine with it, maybe you only have to give one other injection.
Okay.
So less epi for a smoker?
Probably. I mean, I don't know that it's ever produced. I mean, I've never read any articles. Thurlow had my dentist. Nobody ever said that. And I know we all had heavier smokers, especially 2 decades ago. So it was never an issue. But I guess just to be nice to them, as far as it being, you could, if you had a choice, I probably would use the less epi. Dilution. So used in a 1 in 50,000 concentration, epi produces vasoconstriction through its alpha effects. Once the alpha constriction effect has stopped, the epi produces a definite rebound beta effect. So that's how it goes with the alpha and the beta, with that rebound vasodilatory effect. The lesser effects, you have lesser effects with 1 in 100,000 concentration. So yes, if you had a 1 in 200,000 concentration, it would even be less. So vasoconstrictors must be deposited locally into the surgical site to provide real bleeding control, which we're never going to do. Vasoconstrictors act directly on alpha receptors. Only small amounts of local anesthetic solutions with a vasoconstrictor are required to achieve hemostasis. So it isn't like you have to pump a lot in there. Even just small volumes of local anesthetic solutions with vasal can achieve bleeding, but of course that's if you put it in the site. Medical status of the patient, there's few contraindications are known to vasoconstrictor concentrations that are used today. The benefits and risks of including the vasopressor in the local anesthetic needs to be weighed against using a plane. Establishing the degree of severity of condition is key. Like how severe are they? Diabetic? Are they hyperthyroid or uncontrolled hyperthyroid? Makes huge difference. The concern, a minimal dosage to patients with non-cardiovascular diseases, ASA 2 or 3, controlled hyperthyroid dysfunction, even if they have no clinical symptoms, controlled diabetes, and they have a sulfite allergy. The sulfite allergy is going to come out if you use epinephrine because it has sodium sulfite as the preservative, or sodium bisulfite. So that would matter. So we always are going to use, this is kind of just common knowledge, we're always going to use minimal dosage as we can, even if the patient is healthy. So patients receiving MAO inhibitors, tricyclic antidepressants, which I have to say is just about everybody. I mean, I'm always with my patients. It's like, I want to touch you. You're on no meds. Most everybody is on something, so we don't want to overload. We're going to do what we normally do, which is use the most minimal amount to get the job done. So they show no great risk with only a minimal dosage of epinephrine. A controlled ASA 2 or 3 with vasoconstrictors is just a relative contraindication if administered minimally 2 cartridges and slowly. It matters how you inject. Some dentists will inject super fast, and some hygienists will. They just forget, or I guess don't care. That's going to be a little more painful than if you inject slowly, and it's going to absorb differently if you slowly inject versus just get in there with a syringe and, and then it's in. So someone with over 200 systolic and 115 diastolic blood pressure should not receive any kind of elective dental care until their condition is treated, or until, the doctor would okay it. So naturally they shouldn't have anesthetic because they shouldn't even be treated even without anesthetic. ASA 3 or 4 with poorly controlled severe cardio disease is too great a risk for any kind of elective dental care. Also, once again, a heart attack within last 6 months, daily anginal episodes, refractory cardiac dysrhythmias. Refractory meaning even though they're on medication, it's not doing any good, kind of hopeless. Poorly controlled and clinically evident hyperthyroidism, which means bulging eyes, tremors, high temp, etc. And always use 1 in 100,000 if you're sensitive to catecholamines. And I'm not even sure, they don't really, don't even go into any more of it or try to understand that, just know it. Because the questions aren't any more that I've seen aren't any more than that, and that's why I put it in there. Medical status of the patient, vasoconstrictors do contain sodium bisulfite or sodium sulfite. It's an antioxidant to prolong shelf life of the vasoconstrictor to 18 months. It can produce a slightly slower onset, but only slightly. Sodium bisulfite is the most frequently used antioxidant in local anesthetics today. But it can produce an allergic reaction because it's like the sulfites that they spray on vegetables in the grocery store to make them appear so shiny and fresh and inviting. And so those are allergens to some people, and so is sodium bisulfite, the sulfite in there. So if they have an allergy to that, they have to use 3% mepivacaine plain. That's the only other thing we have. So sodium bisulfite leaves the local anesthetic slightly more acidic, and the pH drops than without a vasoconstrictor. So your vasoconstrictor, first of all, your local anesthetic is slightly acidic. It's like a 6 point something, and our pH is 7.4. So it's plain, it's slightly acidic. So then we're going to add epinephrine or a vasoconstrictor to it, and a vasoconstrictor is acidic. So that's going to lower maybe the pH to like a 5 something. It's going to sting more. That's why it's important. It's going to be more acidic. And then when they put the preservative in there, which is acidic, then it's going to maybe drop the pH of that entire solution down to like a 3.5 or a 3.4. And now it's going to be, don't be surprised if when it starts to go in, if they're wincing, I'm like, ooh, because it'll just take, maybe 5 seconds for the body to balance out, but it's not going to feel pleasant for, a few seconds. 2% lidocaine, and I want to say that because a lot of times when people are wincing, you get the feeling that you're doing it wrong. You're not doing it wrong. It's the local anesthetic more that the pH that's is the problem. We can do nothing about that. It has to be in there. So 2% lidocaine plain is already slightly acidic. Sodium bisulfite in the blood vessel causes it to drop even further. Sodium bisulfite contains more cations, charged RNH positives than base. So the diffusion into the axoplasm is slower. And so it has a slightly slower onset. So for test questions, you need to know that, but in real time, you don't see much difference. So in dentistry today, adequate pain control of sufficient clinical duration and depth is difficult to achieve without including a vasoconstrictor. So it should be considered just routine to include the vasoconstrictor unless it's contraindicated by their medical status, or if they're ASA 4 or above, which you won't be seeing much of, or by if it's just really a short treatment. So now we're going to talk about hyper and hypo responders because this makes a difference. We'll go more into it in chapter 4. But for quiz questions for now, hyper responders are, back it said that it matters on the toxicity and the blood level of all those other things, but it also matters of how the individual patient responds to it. This is what they're talking about. Some people are hyper, some are hypo. Most people are right in the middle and fine. But hyper responders, they have tremor of arms and legs, could have drowsiness, overly responders with a duration of anesthetic longer than normal. So you meant to put epinephrine in it so it will last 60 minutes. But you're getting ready to think that, oh gosh, pretty soon I need another half hour. I'm going to need to inject them again in this area. And maybe they're like, no, I'm fine. I'm fine. And you're like, okay, so you wait 10 minutes and they're still fine. And you wait another 10 minutes and they're still fine. These are the patients we love because we can keep going and we know that they're not in pain. We don't have to inject them again. So these people have a longer duration. And if you don't give them the amount that they're supposed to have, like if for this injection they need a third and you only give them a half, then they could start having, you only give them a quarter or a stopper full, then they may have adverse reactions when they're given less than normal. Hypo responder is the exact opposite. They're under responders. So you give epinephrine because you know it's going to last 60 minutes, and they're going to tell you in maybe 15 minutes, 30 minutes, even up to 45 minutes, I don't feel it anymore. And you're like, how could they not feel it? I just gave them a cartridge and a half, you know, or whatever. And they're like, I don't care. I feel it. Well, we have to believe our patients. And they are probably a hyporesponder. They need a much higher dose to show any actions. Hypersensitivity. If hypersensitivity refers to an allergy, hypersensitivity is an allergic process that involves an antigen antibody response. So true allergies, allergic responses are not dose related. So when we talked about allergies, it's not exactly dose related. Most people are not allergic. They'll tell you, my dentist told me I was allergic to local anesthetics, or my dentist told me I was allergic to Procaine. Well, first of all, we don't use our Novocaine, which was Procaine when it started out. We don't use Novocaine anymore. And secondly, if there is really a true allergic response to a local anesthetic without a vasoconstrictor, just the parent compound, then usually those people, it's on paper. They have a medical paper saying so. But we have to go with our patients and go with what they're saying. But just so that you know, true allergic responses. Now you can have an allergic response to the epinephrine, and it's not the epinephrine, it's the sodium bisulfite in the epinephrine. It's the preservative that's the issue and causing the pH to tank.
Will it always be the preservative that they're allergic to?
Yeah, because there's no known allergies to epinephrine, and there's no known allergies to the parent compound. Like if you use mepivacaine and it's plain with no vasoconstrictor in it, there's no known allergies to those. It's when you start, unless you're talking about the esters, okay, which we're not going to talk about. Other injectables, amide injectables, we don't have to worry about that. We only have to worry a little bit about prilocaine because of hemoglobinemia.
So right now, do we need to be able to differentiate, like knowing whether if they're allergic to this, what we should use instead? Or should we just be getting the basics of like what is in each thing?
Get the basic, what is in each thing.
Okay, because earlier you said something about like if they can't use this, then you should know to do this. And I was like, oh, I don't know that yet. Okay,
well, I don't think there's anything in there, but I imagine the only thing that I would have if it's in there, because I get mixed up between the pretest and the actual quiz. The only thing that it possibly could be in there is that if you can't use if you can't use if you can't use an anesthetic with a vasoconstrictor, what would you choose? And it would be mepivacaine. Oh yeah, I guess there is some in there actually. But they would be on your study guide. Okay. So if you look at the study guide, if there's anything in there, then that's what I would pay attention to right now.
Okay. I feel like I'm still trying to get the basics of what's in everything. So I was just making sure I didn't need to go further into knowing what I should use and substitute for other things.
Okay, I'm looking at it right now. Hold on. I don't think there is. I think it's basic knowledge. Yeah, because we haven't gone, the next chapter is going to be over the anesthetics. I think after that, you need to know a little bit more. I don't think at this juncture. because chapter 4 is going to go through each anesthetic so that you get what they are. All right.
Okay, thank you.
You're welcome. Have a good one.
Bye.
Bye. We'll have a quiz over chapter 2 on Friday.